Good afternoon, everybody. On this occasion of Happy Doctors Day, I, Dr. Deepak Rohela, consultant in Manipal Hospital, would like to welcome Dr. Sunil Das. Dr. Sunil's long illustrious career of 30 years, he has been on the forefront of almost all developments that have ever happened in the field of orthopedics, especially in hip and knee surgeries. He's had multiple visits to very famous hospitals all over the world, including Germany and the US, where he has done his training and observed a lot of things. I would like to ask him a few questions. Dr. Sunil Das, can you just give me a short gist of your last 5 years of your career? What has it been?
Namaskar, Dr. Rohela, and Happy Doctors Day to you also.
Thank you.
Since last 5 years, what I found is the technology has gone far ahead. कहीं जितेबाला आम टेक्नोलोजी सपोर्ट नौचु इन द फील्ड ऑफ ऑर्थोपेडिक्स एंड जॉइंट रिप्लेसमेंट इसेंशियली वेयर रिसेंटली रोबोटिक सर्जरी एंड कंप्यूटर navigation सर्जरी has evolved over last five years period. It gave us nothing else except a perfection. माने जोटा आम मैनुअली करूँ गोटे पर्टिकुलर वे रे वर्तमान रोबोटिक सर्जरी कि कंप्यूटर navigation सर्जरी बहुत गुड़ाए परफेक्शन आनी in the field of hip replacement and the field of knee replacement. I have been to different countries in recent past. In last 3 years, I have done extensive traveling, especially to Israel, where I did my robotic training. Then I went to US, I went to France, I went to Germany, and learned the technique of robotic-assisted surgery, computer navigation hip surgeries, minimally invasive surgeries. And practically I started, when I started doing robotic surgery, then I saw myself that my patients are far more happier than they were used to 5 years back when I used to do manual replacement.
Yes.
Now, how robotic helped me in this regard? Because robotics is not only assisting me in surgery, it also helps me in planning. It helps me in understanding my joints, my knee joint, my hip joint, very, so to say, very correctly. I can assess my preoperatively my joints. Then I can take a help of a robot and I can do a much better, so to say, replacement in cases. Actually, hip replacement is a very common surgery, as you also know. Everywhere it is being practiced, hip replacement, total hip replacement in all government medical colleges and in corporate hospitals. But of late, what has happened is the approach to the hip has changed. People are doing true minimally invasive surgery. Earlier, we were doing minimally invasive surgery, but right now, what we do is we are going through a total muscle sparing approach. Earlier used to approach the hip from posterior aspect, from sides. Right now we can approach the hip from the front with a very small incision, maybe 5 to 7 centimeter incision, and between muscle plane. We don't have to, माने आमको किसी मसल आउ काटिबा को सार पड़ुनी. आपण भी देखिथिबे जेतो आमे मिसिक सर्जरी करूचे, we have to go in between muscles, in between vessels, in between nerves, so that we can do definitely a very painless surgery. When post-operatively patient is having very less pain, the liminal discrepancy, sometimes what happens, जितेबाला आम लेटरल पोजिशन रे किंबा पेसेंट को रखी सर्जरी करता जोटा कि अर्लियर अप्रोच रे पोस्टीरियर अप्रोच हो कि लेटरल अप्रोच हो सेटा लिम्ब लाइन डिस्क्रिपेंसी रे टिके अधिका चांस थाए सेठी आप प्लेसमेंट कर कंपोनेंट हिप रो माने फिमोरल साइड रो एसिटाबुलर साइड रो सेतेबेले कोन रुहे टी कंप्लीट मान पोजिशन हेबार चांस थाए जोटा कि आमर ऑन टेबल सीएम सेतेबेले भी थाए आम ऑन टेबल सीएम रे नै कि देखु भी आमर गुडा मैनुअल गाइड अछि किंतु से गुड़ाक जेहेतु पेसेंट पोजिशन टी ऑड थाए तो परसेप्शन से अनुसार हुए नहीं सीआर पिक्चर रे भी we used to stand our patient, walk our patient on the same day afternoon, and आमर फ्यूचर प्लानिंग अच्छी जब आम डीए सक्सेसफुली आम एस्टाब्लिश करदेलु we can do a day care surgery also for total hip replacement. That means patient will come prepared. मतलब तार प्री ऑपरेटिवली इवैल्यूएशन आगरू हो से सर्जरी दिन सकाळे पेसेंट एडमिट हम एंड बाय इवनिंग ही विल बी डिस्चार्ज होम हैप्पीली.
ଆପଣ ଭାବୁଛନ୍ତି that DAA is giving you enough confidence that patient is able to navigate, he will feel nearly normal next day itself, like same day ଯଦି ହେଉଛି ତ next day ତାକୁ ଫିଜିଓଥେରାପିରେ କିଛି ପେନ୍ ମେନ୍ କିଛି ଅସୁବିଧା ହେବନି ଆପଣ କହୁଛନ୍ତି?
डेफिनेटली ଯେତେବେଳେ ଆପଣ କିଛି ଇଣ୍ଟରନାଲ ଟିସ୍ୟୁ ଡିସେକ୍ସନ୍ କରୁନାହାନ୍ତି କି ମସଲ୍ କାଟୁନାହାନ୍ତି, ୟୁ ଆର୍ ଗୋଇଂ ଇନ୍ ବିଟୱିନ୍ ମସଲ୍ସ, ଆପଣ ଭାବିପାରୁଥିବେ ତାକୁ ପେନ୍ଟା କମ୍ ହେବ। ସର୍ଜିକାଲ ପେନ୍ ରହେ ପୋଷ୍ଟର ଆପ୍ରୋଚରେ, ଲେଟରାଲ ଆପ୍ରୋଚରେ, କିନ୍ତୁ ଅଧିକା ଥାଏ। ଆମର ଯେତେ ଗୁଡ଼ାଏ DA କଲେଣି ମୁଁ ନିଜେ ଦେଖୁଛି କି post operative pain are very less, and we will be able to do daycare surgery, at least not in 100% cases, but in around 40-50% cases we can discharge patient on the second day of surgery. That is my expectation.
That is interesting. A hip replacement, DAA and computer navigation upon combination you were mentioning the use of computer assisted hip replacement.
That is what my training is all about. Last month I went to US for training on direct anterior approach with computer navigation. Computer navigation कौन करिवो ना intraoperatively आपनकर जेमती component positioning हला, component sizing हला, आपन leg length discrepancy हला, एगुडा सब avoid करि परिबे when you have a computer to assist you. Computer will help you in planning of the surgery, execution of the surgery, and in between जदि को सर्जिकल स्टेप रंग गला ताहले आपन को भी गाइड करि परिबो। तो जेतेबेले DA साथे आपण कंप्यूटर असिस्टेंस नउचंदी ताहले सर्जरी आउरी गोटे परफेक्शन लेवल हायर लेवल को चल जाउची। तो अल्टीमेटली एगुडा सब आमे जो ऑफर करूचु पेशेंट बेनिफिट पाई। डेफिनेटली मैं लॉट ऑफ सेंटर आउटसाइड ओडिशा and Pune and Maharashtra, Delhi, the people have started doing DA, and they are promoting DA just because patients are getting benefited, because their pain is less, we are able to rehabilitate those patients very early, and ultimately patients are very happy.
What about cost factor with navigation?
When we think about cost, the machine has its own cost. As you know, in robotic surgery, it is around costing around 50,000, and standard surgery maybe hardly 10 to 20,000 it will take, nothing more than that. If you will take assistance of computer navigation while doing direct anterior approach, or as such, if you don't want to do a computer navigation, if you are simply doing DA, then it's just like a normal THR, it will come in normal THR price.
So with the computer navigation, is there any long-term better or worse situation?
What study says, DA has long been started in West. Since 2010-12, people are promoting DA, and in West more and more implant instrumentals they are evolving. What their study says, at the end of the 10 years, patients are very happy. The intraoperative complications rate, limb discrepancy, infections rate, pain score, all are much more satisfactory. So I think DA will give much better result than the traditional approach like posterior approach, lateral approach, and it will give better opportunity for young orthopedic surgeon especially to give best result to their patient if they will start doing hip in direct anterior approach.
If you don't mind, my next question I want to ask you, you have extensive knowledge about hip replacement. If tomorrow your father needed hip replacement, what would you do and why and how? For your own father, what would you say, like, because he's something very revered for you?
A thing is that when hip replacement in elderly depends on lot of things. Suppose somebody is very osteoporotic, suppose somebody is having very difficult hip with earlier he has been operated somewhere else, then you can do a DA, but revision surgeries are a bit difficult in DA approach. Primary surgery, yes, you can do at any point of time. If I am operating on some of my patients, even my father, I should be doing in DA, that goes without saying, because I know my father can work the same day or next day morning, and he don't have much pain, I will be able to rehabilitate early. But in revision scenario, suppose surgery has been done earlier and you are planning to revise, then this approach is a bit difficult. But still, if you are trained well, you can do a revision with the DA also. But at any point of time, my approach to THR has changed. after my training, because I have seen result outside. I have seen patients become much happier. I have trained under very big surgeons, and Dr. Bagia in USA at California, and I have trained in France under Mr. Chang. So I have very much faith on DA, and I am seeing that my patients are happy. So at any day I will opt a direct entry approach over other approaches.
Good, thank you. Just moving to the knee joint test that you have now started doing with the patient for your knee replacements.
Since I have started doing robotics, now Odisha, as you know, is picking up in robotic surgery. Many hospitals are now using robot, they have robot, they have started doing robotic surgery just because it is giving a very good result. Now what we are adding this month or next month is unicondylar knee replacement, which earlier we were doing manually, and many centers are doing manually, but we are planning to start fast robotic assisted unicondylar knee. That means a partial knee replacement may be coming month, and I had undergone training last month on partial hip replacement also. So we will be definitely doing unicondylar replacement robotically maybe from next month onward, because when you do a uni in comparison TKR, doing a manual TKR maybe give you equal result on long run when compared to robotic TKR. But when you say unicondylar knee replacement, but the perfection of implantation of that prosthesis, the way you orient your prosthesis inside your knee when you are doing partial knee replacement, and how you balance your soft tissue is very, very important. So in those cases, robot will definitely come to your rescue. If you don't know, or even if you are experienced, if you did any wrong in placing the implant or in balancing knee in case of unicondylar replacement, then you may need to revise that knee maybe next month, maybe within a 1 year. That knee won't last, patient will suffer. But when you take a robotic help, then definitely you can replace your uni knee perfectly, and you can balance your knee perfectly, and it will last very long like normal knee replacement.
So what you are telling me is a unicondylar knee replacement done manually is relatively harder than a total knee replacement, and results are not as good. But if you put a robot, the result becomes as good or even better.
That is what I meant.
Now, who can or who should go for a uni replacement? Who should go for a total knee? How do you decide?
In a knee joint proper, there are 3 compartments. As I have earlier said in my videos, there are 3 compartments. One is inner compartment, outer compartment, and one is below the patella, जोटा को आमे मलाई चक्की कहूँ, चक्की बोन कहूँ. तो 3टा compartment जो completely worn out हो जाए, arthritis involve हुए, at that time you do a total knee replacement. But when one of the compartment is involved, you can do a knee preserving surgery, what we are mostly doing, or you can do a unicondylar knee replacement. Again, the what I can say, the indications are very well defined, where you do a knee preserving surgery or where you do a partial knee replacement. Those section of patient, very few number of patients, where you do a unicondylar knee replacement, they are young mostly, maybe around 45 to 50 or 60 years of age, and they have one compartment involvement. The ligaments of the knees has to be properly there, they should not get torn or involved in other disease process, and then you can give a very good result. Patient that if you will do a perfect unicondylar replacement, that may last for lifetime.
So a unicondylar knee replacement robotically done, will the patient have a completely normal return to activities that he was experiencing before, or will there be any limitation?
In a uni knee, we are preserving the joint. We are not replacing anything, so to say. We are only replacing the cartilage, the worn out part of the cartilage. Okay. So its patient will feel just like normal, unlike total knee replacement. In total knee, we are replacing the entire knee joint. So the we take out sometimes ligament posterior cruciate. So patient may not feel a normal knee joint, but unique knee joint, the ligament will be there. We are replacing only cartilages. So definitely patient will feel his or her knee very normal.
Learning to use the robot with the unicondylar knee replacement, is it hard or does it require experience? Like, do you have to have 50, 60 surgeries before you can say it is good, or
yes, definitely actually what I can say is you must be very well experienced to do a basic knee replacement first. You have to have a proper training. You have to have a proper training under your mentor. What I can say, you should be doing those surgeries or assisting those surgeries or teacher for at least 1 to 2 years. Then you should start doing your normal knee replacement, be 100, 200, 300. Then you start doing unicompartmental knee replacement. That is how I have learned and my teachers have learned earlier also. And then you start giving results. If you do 1 or 2 cases a year or 6 months, then you may not give that much of result. But consistently you should be doing, and the surgeon has to believe on unicompartmental knee replacement, then only you can give result to your patients. But when you take a robotic assistance, then I can say the way I had undergone training, even a average surgeon can give a very good result. Because replacing those components manually, you need much more experience. But when robot comes to your rescue, now if you have a robot and you have a basic training on knee replacement, you can give equal good result. That is what my experience is.
that is nice, that is interesting.
So definitely robotic assistance will enhance your surgical skills and will improvise your long-term result and short-term result.
Before we close up, I just want you to give us 1 or 2 pieces of information and advice that anybody watching this video can use or learn, and then what he needs to do to take care of the relatives he has who have knee replacement or hip replacement problems. What's the advice will you give?
Actually, very good question, sir. Whatever you have asked me, everybody should know, at least my patients should know what exactly we are doing at Manipal Hospital. Our team is doing at Manipal Hospitals. Actually, hip and knee replacement are no more new surgeries.
They are very common.
It is very common. It is done everywhere. Then what we are doing extra at Manipal Hospital? That is what this video is all about. What is new in hip and knee replacement? One is a truly minimally invasive direct anterior approach in hip replacement. Then anterior advantage hip, that means with the direct anterior approach to the hip, you take computer navigation assistance, that we will be bringing maybe in next month adding, or 1 or 2 months. And third is a robotically assisted unicondylar knee replacement. And finally, of late, as you have knew, we are getting lot of revision cases. In last week, we have revised a multiple time operated hip replacement by doing a CT map. We did a CT scan, we mapped his hip joint, we sent to outside the state to recreate a patient specific acetabulum because there was a big bone loss. So CT mapped implant, patient specific implant, right now we are using, because we are getting more and more hip replacement as this surgery is being done everywhere, and we are receiving a lot of complicated cases. Those are the few areas of hip and knee replacement what we are practicing. So what I can say is, technology being perfection, your experience counts much, and the number of surgery you do, you got more experience and you serve your patient in a much better way. That is what it is.
So what I can sum up from your discussion is Manipal Hospital is now emerging as a center of excellence, especially at the very high end complicated work, and the very innovative technologies of hip and knee that are just appearing right now in the forefront. They may become very common in 5 years, but Manipal is definitely leading the race. Is that correct?
Yes.
Thank you, sir. Thank you so much for your time.
Thank you.